I would like to welcome you all into today's educational nephrology webinar conducted by Africa Healthcare Network, which is normally being conducted every Thursday evening at 6 East African time and 5 Central African time. Today's topic is the KDIGO CKD guidelines in diabetes. And we are lucky that we have Professor Hiddo Lambers Heerspink. So Dr. Lambers, we have the audience from all over Africa, East Africa, Kenya, Uganda, Tanzania, Rwanda, Burundi, and also from South Africa, Egypt, and many other countries from Africa. So the audience is from all over Africa. I'll go through the short bio of Professor Lambers. Professor Hiddo Heerspink is a professor of clinical trial and personalized medicine. He's a clinical trialist, Department of Clinical Pharmacy and Pharmacology, University Medical Center, Groningen, the Netherlands. He's also a visiting professor, University of New South Wales in Sydney. He's also in the auditorium member, Clinical Journal of American Society of Nephrology. Professor Lambers' research interest focus on optimizing current treatment strategies and finding new therapeutic approaches to halt the progression of renal and cardiovascular diseases in patients with diabetes, with a specific focus on personalized medicine. So Professor Lambers, I would like to welcome you and start your presentation. Thank you very much for joining us, Professor.
Thank you very much, Dr. Ginda-Magwabe, for the kind introduction. Ladies and gentlemen, it's my pleasure to participate in this meeting today and hear that there are so many people from different countries. It's one of the advantages, I would say, from COVID, that now I'm able to speak to you all while being at home. Although I hope that in the future I can visit one of you in your home country and talk in more detail about diabetic kidney disease, new treatments that we are developing, and importantly, implementing these new treatments for your patients in your country, taking into account the specifics of your country and the level of care and opportunities for implementation in your country. Today, I'm going to talk about the new diabetic kidney disease guideline. This guideline was published at the end of October. It was developed and started in 2019, early in 2019, when the guideline committee came together, started to review the literature and decided the topics of the guideline. That process took until, let's say, early this year, after which the guideline was refined, rewritten, and finally published a few months ago. And the timing of this publication is, I think, very timely given the improvements in the care for patients with diabetic kidney disease now with SGLT2 inhibitors, having demonstrated that we can indeed reduce the risk of kidney failure and cardiovascular disease in patients with diabetic kidney disease if we consider SGLT2 inhibitors in the treatment regimen. I'm not sure to what extent SGLT2 inhibitors are available in your country. I will be talking about the treatment guideline, as I said, and that will take about 30 minutes, and we have about 20 minutes after that for questions and answers. So I'm now going to share my screen, and I hope this will work. It usually works, so it shouldn't be a problem. So the management of diabetes in chronic kidney disease, the new KDIGO guideline. So my disclosures are listed here. I'm a consultant to a number of pharmaceutical companies with whom I work together to develop new drugs, and I have received research grants from some of these companies to do clinical research in my own university. So I'll be talking about the comprehensive care of patients with diabetes and chronic kidney disease. We'll then be talking about glycemic monitoring and targets, HbA1c targets in patients with diabetic kidney disease. We'll spend a few words on lifestyle interventions, and we'll then focus on anti-hyperglycemic therapies in patients with diabetes and CKD, and we'll close with approaches to the management, the comprehensive approach to management involving not only caregivers, but also patients and their families. So we all know that averting symptomatic hyperglycemia is important to reduce the risk of microvascular complications. And this has been demonstrated in a number of studies where it was shown that more stringent A1C control, for example, in the DCCT, 7% HbA1c versus 9% HbA1c reduced the risk of microvascular complications with 50 to 76%. And similarly, in the UK, the United Kingdom prospective diabetes study, it was demonstrated that A1C levels of 7% versus 8% reduced the risk of microvascular complications by 25%. And the greatest benefit with reductions in HbA1c is achieved when HbA1c levels are higher. There's uncertainty regarding the benefits for macrovascular endpoints, such as myocardial infarctions or stroke. It also appears that these benefits emerge slowly, while the harms of glucose control and the adverse effects of medication can be present more directly. So what do we know? What have the studies shown so far? This is a meta-analysis of 5 studies that have focused on microvascular complications, specifically the onset of microalbuminuria as one of the first manifestations of diabetic kidney disease. And what you appreciate from this slide is that overall, all these studies, except actually one, demonstrated that more stringent HbA1c control significantly reduced the risk of microalbuminuria. And if we look at all these studies together and we analyze them together, we see that the risk is reduced by 41%, as shown here in the graph. So clearly there is a benefit for more stringent, tighter glycemic control on the progression of kidney disease. And this is furthermore illustrated in this study, which I did together with my colleague Vlado Perkovic in Sydney, where we're able to demonstrate that more stringent HbA1c control in the ADVANCE trial, which was a trial in patients with type 2 diabetes, elderly patients older than 50 years with multiple cardiovascular risk factors, is associated with a 65% risk reduction for end-stage kidney disease. So it's not only microalbuminuria that we are able to reduce, but also the clinical endpoint end-stage kidney disease for which dialysis or kidney transplantation is required. Now, what about the benefits for macrovascular endpoints? As I already mentioned, these benefits are less clear. But if we look at the big studies that have been conducted in the past, like the ADVANCE, like the ACCORD study in thousands of patients, and we analyze these big studies together, we again see that there may be some benefit for macrovascular endpoints like myocardial infarction. Again, if we look at the total effect of these studies, and you can see that at the bottom of this forest plot, you'll see that the risk reduction is reduced by 18%, which is statistically significant. However, you need large sample sizes to demonstrate this effect, which indicates that the absolute risk reduction is probably modest. Now, how do we monitor glycemia in patients with diabetic kidney disease? We always use HbA1c, but there are some disadvantages by using HbA1c, and the alternatives have been developed, like glycated albumin, or perhaps fructosamine, or perhaps other studies have shown and have tested 1,5-anhydroglycitol. What are the advantages and disadvantages of each of these measures? This is a table that has been published in the guideline, and at the top you'll see the advantages of HbA1c. It's a long-term glycemic marker. There are standardized HbA1c assays, but HbA1c by itself has also a couple of limitations, in particular in patients with diabetic kidney disease, because these patients with diabetic kidney disease have reduced EPO activity, have iron deficiency, and that may alter HbA1c levels and thus may bias the reading that you obtain when you measure HbA1c in a patient with diabetic kidney disease. So alternatives have been developed, like glycated albumin or fructosamine. The advantage of these is that they are short-term glycemic markers. They predict outcomes just like HbA1c, or perhaps even better. And there's no effect of renal anemia on the measurement itself. But again, these measures also have their disadvantages. For example, glycated albumin is increased when there's protein loss, or they are changing when there's chronic inflammation, or when there's dyslipidemia. And in fructosamine is increased level in iron deficiency anemia. It is also increased when there's protein catabolism. So these measures are also not ideal. And finally, 1,5-AG, the bottom row, has some advantages, but as you can read from the table, there are also a number of disadvantages. So we are still using HbA1c nowadays, although we know that there are disadvantages, mostly because of tradition and the fact that there are standardized HbA1c assays. HbA1c correlated moderately with glucose when measured by fasting or morning blood levels, or when we used continuous glucose monitoring. And in addition, correlations of directly measured glucose with all three glycemic markers, HbA1c, glycated albumin, or fructosamine, were progressively worse with more advanced CKD stages. So although alternatives have been developed to HbA1c, like glycated albumin or fructosamine, these are also not ideal when there's more advanced chronic kidney disease. So the recommendation from the guideline is that the guideline recommends HbA1c to monitor glycemic control in patients with diabetes and chronic kidney disease. But the guideline also mentions that we have to be careful. In particular, the measurement may be too high when there's metabolic acidosis or when there is carbamylation. But the measurement may also be too low when there's anemia, transfusion, EPO, or iron supplementation. So we have to take these factors into account when we start interpreting HbA1c values in patients with diabetic kidney disease. Now, an alternative to measuring HbA1c is daily glycemic monitoring with the use of continuous glucose monitoring, CGM, or self-monitoring, which may help to prevent hypoglycemia and improve glycemic control, in particular when anti-hyperglycemic therapies are used, which are associated with a higher risk of hypoglycemia. Which are these therapies? Insulin, SU derivatives, the glitinides, they are associated with a higher risk of hypoglycemia, and thus the rationale for using self-monitoring of blood glucose or continuous glucose monitoring is higher in these patients. At the other hand, the newer oral anti-diabetic drugs, like the DPP-4 inhibitors or the SGLT2 inhibitors, or traditionally metformin, are associated with a lower risk of hypoglycemia. And so the use and the rationale for using self-monitoring or continuous glucose monitoring is also less when we use these drugs. So what about CGM? CGM measures continuous glucose, and it established the time in range. And the goal per 24-hour to have time in range glucose control should be more than 70%. The goal to prevent hyperglycemia is less than 4% of per 24-hour. So it established a glucose management indicator, and monitoring is particularly useful when the GFR is below 30 and when treatments with hypoglycemic inducing medications are initiated or are maintained. And what do you get from such a continuous glucose monitor? This is a report, a typical report. It indicates the time in range. So if you look at the green or the colored bar, the green area indicates the target range. So the time in range for this particular subject, it was 47%. 23% was too high. So 23% of the time, 5 hours, 31 minutes, the levels were too high. And even 4 hours, 48 minutes, 20% of the 24-hour time interval, the measurements were very high. There was also about 2.5 hours when the measurements were actually too low. So it gives you a very detailed assessment of the time in range and out of range for each individual per day. So the guideline recommends some future goals for future research. And I always consider this future research goal extremely useful when thinking about new studies, what you can do in your practice. So the guideline recommends that new methods to identify patients for whom HbA1c has a biased estimate of long-term glycemia should be developed, and alternative approaches to monitor glycemia should be considered and developed in such patients. In addition, the guideline mentions that we should develop methods to identify patients at high risk of hypoglycemia or poor glycemic control who may benefit from CGM or SMBG. And that could be patients with a very low GFR, it could be the elderly population, it could be patients who have been receiving treatment with SU derivatives and insulin in combination. These are the potential patients who may particularly benefit from continuous glucose monitoring. We should also develop and validate alternative biomarkers for long-term glycemic monitoring because, as I indicated, the current alternatives, fructosamine or glycated albumin, are not ideal. And we should test whether CGM helps to control glycemia and improve long-term clinical outcomes. In addition, we should evaluate the value of CGM and metrics like time in range for patients with chronic kidney disease, and we should establish if a lower glycemic target is associated with less progression of established chronic kidney disease. Finally, establish optimal glycemic targets in a dialysis population of patients with diabetes. This is an important goal, often neglected, and important to establish optimal glycemic targets in that population as well. So when we're thinking about HbA1c control in patients with chronic kidney disease, we are balancing more stringent versus less stringent control. Of course, the advantage of more stringent, the disadvantage is more stringent control, no hypoglycemia. That's something we should consider. Less complexity, polypharmacy, lifestyle or metformin only, short disease duration, long life expectancy, no cardiovascular disease. These are conditions where more stringent control can be considered. Less stringent control should be considered if there's a history of severe hypoglycemia, or when there's already a high burden of therapy. If patients already receive a lot of therapy, should we then add more therapies to achieve a more stringent control? I don't think so. Also, longer disease duration, a limited life expectancy. I think we can be more liberal in these patients with HbA1c control. Extensive comorbidities, cardiovascular disease is another reason not to achieve a more stringent control, but be more liberal and try to accomplish a less stringent HbA1c control. So we are balancing and trying to optimize for each patient, given the circumstances for each patient, the optimal HbA1c target. And this goes in the direction of personalizing medicine, because not every patient is the same. So in general, an HbA1c control should be achieved between 6.5 or below 6.5 with a maximum of 8. So in everyone, it should be less than 8. And then that levels should be individualized based on a number of factors: the severity of chronic kidney disease, the absence or presence of macrovascular complications, other comorbidities, the life expectancy of the patient, the awareness of developing hypoglycemia. If the patient is not aware of developing hypoglycemia, we should of course not strive for a more stringent HbA1c control. Also, the resources for hypoglycemia and the propensity to cause hypoglycemia should be considered and should be balanced in order not to increase the risk of hypoglycemia. Now I'm going to move to the third section, lifestyle interventions in patients with diabetes and chronic kidney disease. And again, the guideline recommends to individualize the diet, but also states that we have to consider a mixed diet, including vegetables, fruits, whole grains, fiber, plant-based proteins, unsaturated fats and nuts, and lower in processed meats. and refined carbohydrates and lessen sweetened beverages. So think about a mixed meal for every patient that has at least enough fruits and vegetables, proteins from plants and whole grains, which is important. I realize this is not always easy to achieve. In particular, I can imagine it's difficult to achieve in low resource settings, but again, it should be the goal for patients. Now, if you think about lifestyle intervention in patients with diabetes, it's recommended that patients with diabetes and chronic kidney disease should be advised to undertake moderate to intensive physical activity for at least 150 minutes per week, or to a level which is compatible with their cardiovascular and physical tolerance. This is graded 1D, which means that the evidence is not very strong, but at least and backed up by good clinical trials, but at least we start to realize that we have to be physically active for at least a number of hours per week in order to treat diabetes and chronic kidney disease. We should avoid sedentary behavior. So don't sit too much, but walk or stand every day. And physicians should consider to advise and encourage patients with obesity, diabetes, and chronic kidney disease to lose body weight. Particular patients with eGFR above 30 mL per minute should consider to lose their body weight. And again, this is not easy. Some patients can lose their body weight, but the difficulty is to maintain body weight reductions during prolonged follow-up. And we've seen that in a number of clinical trials where intensive body weight lowering was successful for a year, but then over the subsequent years, many patients regain their body weight and increase their body weight to levels where they started off with. So it's important to continue to encourage patients to lose and maintain body weight reductions. Now, what about the use of glucose-lowering medications in type 2 diabetes? This is, of course, an area of active research. It started with the DPP-4 inhibitors a couple of years ago. Then the GLP-1 receptor agonist came, and nowadays everyone is focused on SGLT2 inhibitors, given their profound effects on heart failure and on chronic kidney disease in particular. And these are the two main complications of patients with diabetes and chronic kidney disease. Heart failure is the most frequent cardiovascular complication. And of course, patients with chronic kidney disease are at risk of progressing to end-stage kidney disease. The American Diabetes Association, in combination with the European Diabetes Association, has published this guideline in 2019, which again goes into personalizing and individualizing treatments. So basically, the guideline mentions that for every patient, lifestyle advice, including weight management and physical activity, is important. This is in general for every patient with type 2 diabetes. And then there is a certain preference based on the patient's profile. Patients in whom heart failure or chronic kidney disease predominates should receive an SGLT2 inhibitor because these drugs have shown to slow progression of chronic kidney disease and heart failure. Patients with established atherosclerotic cardiovascular disease should receive a GLP-1 receptor agonist because these drugs have shown to reduce the risk of cardiovascular outcomes, in particular myocardial infarction, stroke, or cardiovascular death. Then the guideline also mentions that in patients in whom there is a need to minimize weight gain, GLP-1 receptor agonists should be considered, or SGLT2 inhibitors. And then finally, you'll see that at the right of this cartoon, when cost is a major issue, SU derivatives or glitazones can be considered if the HbA1c is above the target. So again, based on the patient's phenotype and other conditions, the choice of glucose lowering and the drug choice is made. Now, what does the guideline for diabetic kidney disease recommends? Well, first of all, as just discussed, lifestyle therapy is extremely important. Physical activity, nutrition, weight loss. And then the guideline states that metformin is the first choice. And metformin can be initiated when the GFR is above 45, but when the GFR falls below 45, we have to reduce the dose. And when the GFR is below 30, we should even discontinue the drug because of a risk of lactic acidosis. It appears from the recent studies that metformin by itself does not increase the risk of lactic acidosis, but often there is a second condition present that together with metformin provokes the lactic acidosis. For example, when patient is when circulating volume is reduced and the concentration, the plasma concentration of metformin is increased, lactic acidosis can develop in the setting of an intercurrent illness, for example, and when there's diarrhea present. Or when when it's very hot outside and the patient is sweating a lot and loses a lot of body water, the metformin concentration in plasma can increase, which may provoke lactic acidosis. So we have to be careful with our patients, in particular when the GFR drops and the risk of lactic acidosis and other conditions, and patients should be educated about it. Now, when the guideline recommends that when HbA1c is not achieved, HbA1c control is not optimal, an SGLT2 inhibitor should be added to the therapeutic regimen. SGLT2 inhibitors can, in most countries, now be initiated when the GFR is above 30. They cannot be initiated when the eGFR is below 30. And they should be discontinued when the patient reaches kidney failure. And then if the HbA1c is still not, and glycemic control is still not achieved, other diabetic treatments can be added. For example, GLP-1 receptor agonist, according to the guideline, the preferred agent, because GLP-1 receptor agonists have been shown to reduce cardiovascular outcomes, but also may protect against kidney outcomes. And then other drugs can be considered like DPP-4 inhibitors, SU derivatives, insulin, and glitazones. And all of these choices are guided by patient preferences, comorbidities, eGFR, and costs. So it's really, again, individualizing the treatment, but the basis is consistent. It starts with lifestyle therapy, and it's followed by metformin and SGLT2 inhibitors. So what is the suggested approach in dosing metformin based on the level of kidney function? Well, if the eGFR is above 60, start with 500 milligram or 850 milligram once daily and up titrate by 500 milligram or 850 milligram per day every 7 days till the maximum dose. Or use an extended release if the gastrointestinal side effects are present from immediate release. Initial 500 milligram dose daily and up titrate by 500 milligram every 7 days until maximum dose. If the GFR is between 30 and 44, initiate at half the dose and titrate upwards to half of the maximum recommended dose. And if the eGFR is below 30, stop metformin, and of course do not initiate metformin if the eGFR is below 30 because of the risk of lactic acidosis. So annually monitor vitamin B12 because vitamin B12 deficiency can occur when patients are using metformin. So annually measure vitamin B12 if possible for more than 4 years. And monitor kidney function at least annually when the GFR is above 60 or at least every 3 to 6 months when the GFR is between 30 and 60. So what are the choices if for glucose lowering medication after metformin and SGLT2 inhibitors? Just like the type 2 diabetes guideline, there's multiple choices, and these choices have to be based on the patient's characteristics. So a patient with high risk of cardiovascular disease and GLP-1 receptor agonist should be considered. If the patient has a high body weight, we can again consider GLP-1 receptor agonist and avoid SU derivatives or insulin. When costs are an issue, consider SU derivatives. So it's again based on patient phenotypes and external considerations. And this graph that I'm presenting here is also published in the guideline. So you can read and review this cartoon when you're reading the guideline. Of course, we should consider all the different factors that are involved in patients with diabetic kidney disease, because it's not only about kidney disease, cardiovascular disease, there's many other things happening. So the screening detection as we are using in the Netherlands and in Denmark, this is a slide from the Steno Diabetes Center, recommends that we do fundus photography in our patients, that we check visual acuity, that we measure albumin creatinine ratio, blood pressure, that we perform ECGs, that we do the foot inspections, that we assess autonomic neuropathy, erectile dysfunction, that we measure lipids. And even when there's advanced chronic kidney disease present, we measure calcium phosphate, pH, bicarb, electrolytes, and we measure hemoglobin to assess anemia and Now, what about the approach to the management of patients with diabetes and chronic kidney disease? The guideline recommends a structured self-management educational program and recommends that be implemented for the care of people with diabetes and chronic kidney disease. And the objectives of this self-management educational program is to improve diabetes-related knowledge, beliefs, and skills, improve self-management, self-motivation, which is extremely important for individual patients, encourage adoption and maintenance of healthy lifestyles. As I said, it's easy to change lifestyle for a little while, but it's very difficult to maintain for a long time. Improve vascular risk factors, increase engagement with medication, because we know that many patients are not adherent to treatment. If the patient is engaged, the treatment adherence will probably be much better. And in the end, reduce risk to prevent diabetes-related complications and improve emotional well-being, treatment satisfaction, and ultimately quality of life. And that quality of life is extremely important, because for a patient, it's in the end all about quality of life. When we had a meeting a few months ago with physicians, with payers, or even regulators from the FDA and patients, and we asked what is most important, the physicians and the regulators said, well, it's all about dialysis and mortality, but the patients actually said that it's all about quality of life. That's why they're taking medications to improve their quality of life. So how does this approach look like? Well, we have to develop CKD health systems and organize chronic kidney disease care. That should consist of self-management support, delivery, system designs, clinical information systems, and decision support system. But the community should help as well. And we should develop resources and policies to inform and activate patients. And at the same time, through the CKD health systems, we should prepare proactive multidisciplinary teams to help patients as well. Together with that, and these products will interact, we can improve outcomes for patients. And thus, it's not only about the patient itself, it's about the CKD health system, it's about us supporting patients, and it's about the community that should help the patients. So the guideline recommends that we suggest that policymakers and decision makers should implement team-based integrated care focus on risk evaluation and patient empowerment to provide comprehensive care in patients with diabetes and chronic kidney disease. So it's not only about patients, but their environment, policymakers, decision makers who should develop those team-based caregivers around the patients to support them and to promote optimal life. So the summary of the guideline, a new guideline provides recommendations and practice points on the comprehensive care, glycemic monitoring and targets, lifestyle intervention, anti-hyperglycemic therapies, and approaches to the management of patients with diabetes and chronic kidney disease. A patient-centered decision-making and support emphasized throughout. We should optimize diet, exercise, which is the foundation of the care. HbA1c remains standard for glycemic monitoring. Glycemic targets should be individualized. For patients with type 2 diabetes, base drug therapy should include metformin and SGLT2 inhibitors with GLP-1 receptor agonist preferred as next line. And then finally, self-management programs and health systems approaches should advocate for implementation. I'd like to thank you for your attention, and I think we have some time left for questions and answers. Finally, of course, important, I would like to acknowledge all the people who have been working on this guideline. In particular, people from KDIGO, Michael Chung, Amy Early, Melissa Thompson, Wolfgang Winkelmeier, Michelle Diajul, and Marcello Tonelli, and of course the chairs, Peter Rossing and Ian de Boer. Thank you.
All right. Thank you, Professor Lambert. Very, very good presentation. Great presentation, Professor Lambert. So we are going to the question time. If you have any question, please, you can ask direct to Professor Lambert. Any question?
Yeah, just one question.
Yes, Dr. Lloyd.
Thank you very much for your presentation, Dr. Lambers. It is wonderful indeed. In just 30 minutes, you covered the whole of the guideline beautifully. The question I have is, you see, there's so much going on the SGLT2I inhibitors. You have the credence and you have the DAPA CKD, where you are the lead investigator. I presume, I think you are the lead investigator there. Now, there's so much that comes on in renal prevention, renal protection. Now, we also add ACE inhibitors to diabetes CKD. Now, is there any benefit, or are there any trials that compares head-on ACE inhibitors plus SGLT2I against SGLT2I alone, or is there any thought process there? What are your views there? We can actually avoid this multi-drug use if there is this amount of protection. Like your DAPA CKD is a 50% reduction in the EGFR protection-wise.
Yeah, excellent question. And indeed, we're testing on top of other medications every time. So we add more and more drugs to the therapeutic regimen. And of course, we should consider whether we can minimize drug use. And so your question is perfectly right. Unfortunately, because of the current way we are testing these new drugs, it's very difficult to just directly test head-to-head SGLT2 with ACE inhibitors. We could do it nowadays because we know that SGLT2 inhibitors, when given on top of ACE or ARBs, are beneficial. So that would be a trial where we compare patients, where we stop the ACE or ARB in patients and give an SGLT2 and then compare to ACE or ARB. I think you can only do that in patients in whom you want to initiate or you consider to initiate an ACE inhibitor or angiotensin receptor blocker, and then you randomize that patient to an SGLT2 inhibitor or an ACE inhibitor. That requires a large study because I don't know how many patients a week you initiate an ACE inhibitor or angiotensin receptor blocker. It's probably not a lot. So it needs many, many hospitals working together. But it is, I think, a really important, clinically important question that should be addressed. Can we initiate with an SGLT2 inhibitor and perhaps later on add the ACE inhibitor or angiotensin receptor blocker, given that SGLT2 inhibitors appear to be more effective than ACE inhibitors or angiotensin receptor blockers? The study has not yet been done, but perhaps in the future.
The other issue is practically we find that with a lot of the ACE inhibitor use, especially when you have type 4 renal tubular acidosis in a diabetic, and you're using spironolactone as well, hyperkalemia is another major factor that comes on. Of course, we have drugs for hyperkalemia today, but they are going to be expensive, and to the developing world, that is not going to be available. So that's another consideration that I thought that if we can actually do away with the ACE inhibitors and you have such good drugs as the SGL2. Yeah, and I agree that the more study is needed.
Yeah, perfect. You're completely right. And there is some suggestion that if you combine SGLT2 with spironolactone, you may actually reduce potassium levels. It's not seen in every study, but if true, that would be an ideal combination. So definitely worth further considering.
Thank you so much, Dr. Lambers.
Thank you. Dr. Rugajo, you wanted to ask something and of course, take over the, question session. Dr. Rugajo? Okay, so still has, okay, so, yes, Professor Lambert.
Can I ask a question?
Yes, please go ahead.
My name is Dr. Jonathan Wala. Thank you, Professor, for a comprehensive summary. From going back to the SGLT2 inhibitors in diabetic patients, or even diabetic patients, as far as heart failure and CKD is concerned. My first question is: was there any correlation between the degree of reduction in these hard outcomes to whether how much HbA1c was decreased, right? And then my second question is, therefore, if it is there any role as far as macrovascular complications are concerned in monitoring HbA1c for patients whom you have decided to start on SGLT2 inhibitors?
Yeah, good question. There was absolutely no correlation between the change in HbA1c and the risk reduction that we observed. So these effects appear to be completely independent of glycemic control with SGLT2 inhibitors. And that's why actually we also studied patients without diabetes in whom we didn't see a reduction in HbA1c, but still found a significant risk reduction in the clinical outcomes. And you have to remind me about your second question, sorry.
My second question was, therefore, if you have a patient whom you have decided to start SGLT2 inhibitor as your first line therapy, a diabetic patient with probably mild CKD, is there any reason to continue monitoring HbA1c?
Yeah. Yeah, I would continue monitoring HbA1c in those patients, not because to measure the efficacy of the SGLT2 inhibitor, but of course you want to prevent hyperglycemia in these patients, and maybe glycemic levels worsen over time. So I would always consider, I would always continue to monitor HbA1c values, and if they progressively worsen over time, consider another glucose lowering drug to reduce the HbA1c levels, like a DPP4 inhibitor or a GLP-1 receptor agonist. They are more expensive GLP-1 receptor agonists, and thus that should certainly be taken into account. DPP4 inhibitors appear to be very safe. They reduce HbA1c. They don't have a clear effect on clinical outcomes, but at least you can control the HbA1c value. That's why I believe that DPP4 inhibitors are would not be my preferred drug. I would definitely start with SGLT2 inhibitors because of their clinical outcomes effects. But if you want to further optimize glycemic control, DPP4s can be safely used.
All right. Thank you very much. Very good question, answer and question. So there is this question from Akrabi. It's a text message that SGLT and GLP are expensive. We are using gliclazide and glipizide in diabetes CKD. Can you recommend unacceptable sulfonylureas in CKD? Dr. Krabi is from Tanzania.
Yeah, I can fully understand that point. And thus glycosides, glycoside is a good SU derivatives. The first generation SU derivatives have been associated with a high risk of hypoglycemia and body weight gain. The second generations have been associated with a lower risk of hypoglycemia, and thus glycoside is definitely a good consideration. Actually, the Dutch guideline still recommends metformin followed by glycoside, and then using an insulin. We are very conservative in the Netherlands, where I live, with the uptake of new medications. Our guideline will change, but I think it will take a while. So we use also the same drugs as what you are using. Or at least the guideline recommends to use those drugs.
Very good. Another question is from Dr. Rugajo, who says, did the guideline consider the burnout, diabetes, and disturbed renal gluconeogenesis that happens with decline in EGFR?
Whether the guideline considers this?
burnt out diabetes, and disturbed renal gluconeogenesis that happens with decline EGFR.
Yeah, so the kidney produces glucose. So many people, the kidney is actually very important in glucose homeostasis. Glucose is filtered, glucose is reabsorbed. The kidney produces glucose, which is influenced by adrenaline, insulin, and it just plays an important role. When kidney function declines, the gluconeogenesis is reduced, and that's true. But I don't understand whether it's burned out. No, it's mentioned in the guideline, but maybe I interpret the question completely wrong.
Okay, I think it's very clear. Another question, please, and anyone with a different question?
What about the, can I ask one question? What about the GLP-2RA now coming as coming orally now, and there are so many of them in the market now coming out. What would you suggest in terms of the choice between these drugs that are coming out?
Yeah, it's really depending on the patient. My experience is that some patients prefer a subcutaneous injection, in particular patients who find it difficult to adhere to treatment and take a subcutaneous injection. My personal preference is I don't like injections, so my personal preference would be to take a tablet. There's actually only one, it's semaglutide, which is going to be marketed as a oral GLP-1 receptor agonist. But it depends on the patient, and that's why that patient-physician dialogue is so important, to understand and engage patients in the decision what they want to use, whether it be a subcutaneous injection or an oral medication. And it, as I said, it depends on the preferences of individual patients. In general, the efficacy is the same, the exposure is the same, except that because of low bioavailability, the tablet will contain a lot of semaglutide, because there's only a small proportion of the semaglutide reabsorbed in the intestine.
Okay, thank you.
Yes,
And
thank you.
the cost of these drugs
My question is.
Go ahead, sorry. Please go ahead.
Yes, I was asking Professor Lambert. KDIGO recommends the use of HbA1c for the monitoring of glycemic control to our patients. And but you mentioned the other ways of monitoring glycemic control, like glycated albumin, fructosane. Mm-hmm. So is there any country that have been used other methods like glycated albumin rather than HbA1c? Because you say that you know, these are the other methods, yeah, but you recommend KDIGO recommends HbA1c. What about this? Is there any other country that use?
No. So these alternatives have been used in research studies, and they've tried to develop an alternative given the limitations of HbA1c. But HbA1c has a very important advantage. There are standardized assays. There's a lot of experience. Physicians know to interpret the HbA1c value. Perhaps not always in patients with diabetic kidney disease, and they should be aware of potential bias in the measurement when there is low kidney function and anemia, or when there is iron deficiency. So they should know that the HbA1c value does not always reflect the glucose exposure in the body due to these biases. But as soon as they know, as long as they are aware of this, they should be able to interpret the data. These other measures also have their limitations, and as I mentioned, they are not routinely used in clinical practice, as far as I'm aware.
Right. Oh, thank you. Another question is a text message from David Atuhe. How accurate is HbA1c in measurement of glycemic control in CKD patients, and what are the cons?
Yeah, well, I just mentioned those, right? I
Yeah.
mentioned it really depends on the patient. So if the patient doesn't have iron deficiency, doesn't have EPO deficiencies, there's less bias. But at the other hand, another patient who is severely anemic, there may be more bias. So you have to be aware of the factors that influence HbA1c values in order to say how well and how accurate HbA1c is as a measure of glycemic exposure. And thus I recommend, it's beautifully written in the guideline what the positive, negative biases are, and I would recommend you to read it. And there's more in the literature. There's many reviews about this topic, so you can read that as well.
All right. Regarding dietary control, my comment is for patients who have diabetes, at the same time has CKD and is in end stage renal disease, stage 5.
Yeah.
And then we recommend vegetables and fruits as they're 50% of their normal diet.
Yeah.
But then vegetables, most of the vegetables contains phosphorus, and most of the fruits contain potassium. So now it becomes very difficult then, for patients who has end-stage renal disease and diabetes at the same time.
You're completely right. So when we developed the guideline and we're talking about this chapter and we were talking about a lifestyle and food intake, we also had a patient on the guideline, and the patient said, it's so difficult because if I'm now following the guideline, I cannot eat anything because the fruit contain potassium. I'm not allowed to eat phosphate. I'm not allowed to eat sodium. So what, and I should adhere to a low protein intake. So what can I do? And that's correct, of course. So I think that balancing and having a rich diet where you have carbohydrates, where you have proteins, where there is electrolyte intake, not too much, is the best way. In the end, it's also about quality of life, right? If you can only drink water and eat an apple a day, I don't think it will benefit your quality of life as well. So it's that balance, and be aware of trying to balance as good as possible.
And what about the alcohol, the use of alcohol, like the recommended 2 units of alcohol, like a beer, in patients with CKD end stage? Will you recommend that?
I would ban alcohol at all. It's extremely bad for you. So no alcohol intake.
Okay. All right, Dr. Lloyd?
Just like not smoking. Very easy.
Okay. Dr. Lloyd?
Yeah, there's one more question, sorry. It's about the technology used in the manufacturing of SGLT2I or even the GLP-1RA. Do you think generics would come in quickly, or is licensing the issue, or will that take a long time to come in terms of cost reduction, or will there be some sort of competitions with alternative molecules that come, congeners sort of molecules that can reduce costs and time?
I think that these drugs will become more cheap when they are out of patent, and that depends a little bit on the different SGLT2 inhibitors. I believe dapagliflozin is the first SGLT2 inhibitor going out of patent in end of 2024, and of course when they go out of patent, the prices will drop dramatically. Until then, I think there will not be a lot of price changes. In terms of registration, I'm sure the companies will try to do it as soon as possible and change their labels for kidney protection with these drugs. And it depends on the regulatory agencies like the FDA, the EMA, and local regulatory agencies, how fast they will change the labels of these drugs and how fast they will be implemented in clinical practice.
Thank you so much. Yeah, we are still receiving questions. Is there another question?
in terms of atherosclerotic cardiovascular disease, and you have a low GFR, sometimes you have vascular paths clinically, significant vascular paths with peripheral vascular disease, cardiovascular disease, and CKD. So in that sort of situation, would you still use an SGLT2I, or would you go for a GLP-1RA?
I think I would go for GLP-1RA.
GLP-1, yeah, sure.
Yeah.
Thank you.
All right. All right. Professor Ramba, thank you very much for your time. I think there's no more questions. And we really thank you for taking your time and share your knowledge with us. And as you said, it's COVID. We should thank COVID that you had time to come with us.
Yeah, yeah.
We really thank you for that.
Thank you very much for having me, and thank you for all your questions. You can download the guideline at the website of Kidney International, and I hope you find it useful for the treatment of your patients.
Yeah, we would also like you to come on in the future as well. We request if it would be possible, we could contact you through the
Sure, you can always contact me.
Okay, thank you so much.
Thank you very much.
Thank you.
All right, thank you, Professor. I really appreciate for having a great presentation.
Thank
bye
you.
bye.
Bye-bye. Have a nice
all
evening.
Right. So, yes, for the rest of the group, you can download, you can download the metabolic acidosis session that was done by Nicholas Madeus. I think the text message has been distributed by Dr. Mar, so you can read it and then see how you can download that presentation. So we thank you and see you next week for another exciting nephrology webinar next week. Thank you very much. Thank you, Dr. Lloyd. Thank you, AHN. Thank you, everybody.